Hello and welcome to the Masterclass in Non-Muscle Invasive Bladder Cancer, Practical Solutions to Common Scenarios. My name is Ashish Kamath. I'm Professor of Urologic Oncology at MD Anderson Cancer Center in Houston, Texas. It's my great privilege to be joined today by true experts in the field. Dr. Maria Rubal, who is head of the Uro-Oncology Unit at the University of Barcelona in Barcelona, Spain. Dr. Roger Buckley, Chief of Urology, North York General Hospital in Toronto, Canada. Dr. Paolo Gontero, who's Professor of Urology and the Chairman of the Department of Urology in Torino, Italy. And Dr. Arno Stenzel, Professor and Chairman, Department of Urology at the University Hospital Tübingen in Germany. Welcome, everybody. First, Dr. Buckley will be talking to us on optimizing the use of BCG during these times of global BCG shortage.
Well, thank you, Ashish, and it's a pleasure to be here to discuss the urological management of the global BCG shortage. These are my disclosures. I'd also like to thank MEDAC for inviting me. Here's our friend Mycobacterium bovis. BCG was invented in 1921, so it is almost 100 years old and having its centennial birthday next year. Calmet and Gurian invented BCG in the race for a tuberculosis vaccine. It was passed from lab to lab throughout different times in the 20s, 30s, and 40s as a live transmission. So there was a slight shift in the genetic seed. In the late 50s, with freeze-drying lyophilization techniques, this genetic drift has been stopped, and we have the current seed lots as they are for each individual company. Use in bladder cancer came about in 1976 when Morales did his 9 patients, followed by numerous others, including Lamb, doing different randomized clinical trials, showing the BCG was superior to chemotherapy, and then its inclusion in multiple guidelines. BCG production is specialized. It's a bacteria that has its own unique secrets to each company. The life cycle is 3 to 4 months to grow, which is why production cannot be suddenly ramped up. Once it's grown, it has to be freeze-dried and then a cold chain transport process to the different countries. It would take about 7 years to open up a new BCG factory. There are only about 8 to 10 producers of BCG worldwide. There are 2 in North America and 3 in Europe in 2012. There are a number of other strains throughout the world. In North America, there's a single plant that produces the global supply of Immucyst and Oncotyce, and this was back in 2012. And these 2 companies plus MEDAC supplied Europe. In 2012, Sanofi Pasteur had a voluntary stop production, and now, unfortunately, it is permanently stopped after a short resumption of production. Merck also had issues with production. Oncotyce and MEDAC have maximized their production. Various countries have fast-tracked approval of different strains for that particular country. The Tokyo strain is under study in the North American population. But basically, we are looking at 3 techniques of managing BCG shortage. And various countries have no shortage. Some countries have lots of shortage with nothing available, and lots of countries in between. These techniques include triaging patients. Specifically, BCG should never be given for low-risk patients. In the intermediate-risk patients, perhaps only to the patient that has multiple risk factors, and perhaps only give induction only. In the higher risk patients, perhaps you would provide only 1 year of maintenance and perhaps only full dose for induction and then maintenance therapy for the rest, third dose for the rest of the maintenance therapy. So dose reduction has historically been utilized for many reasons over the past few decades. Numerous national and international bodies and associations have all approved it as a reasonable strategy to offer patients during a BCG shortage. EUR 30962 by Odens is the publication that can be used to support theoretically, the dose reduction to 1/3 dose. But the key to this strategy is to pump patients in groups of 3 in the clinic or the hospital. This is that study, and it looked at 1 versus 3 years maintenance and 1/3 versus full dose, and I think we're all familiar with the results. Other options include the use of intravesical chemotherapy, the use of EMDA or synergo hyperthermia with intravesical chemotherapy, upfront cystectomy for the high or very high risk patient is always a possibility and should be considered at the outset. The use of aggressive resection is also considered for certain patients. And there are new IO agents that are currently being used for BCG non-responders, and we're going to hear more about that during this talk. So I'd like to thank you very much, and any questions?
So thank you for that great talk, Dr. Buckley. Let's move on to our first debate. Debate 1 is a intermediate risk non-muscle invasive bladder cancer, low-grade recurrent TA tumors that are small. And the question is, what is the best management? So this is a 66-year-old healthy man, former heavy smoker. Imaging is performed, everything is clear, including the upper tract. The office flexible cystoscopy shows this small papillary tumor that you can see. Visually, it appears to be low-grade TA. Cytology is negative. The patient is taken to the OR for fluorescent-aided TURBT, and no other lesions are seen. The patient is followed with cystoscopy after pathology comes back as TA low-grade. Cystoscopy is done at 3, 6, 12, and 24 months, all no evidence of disease. At 36 months, at the 3-year mark, an office flexible cystoscopy shows 2 small papillary tumors, which also, again, appear to be low-grade TA, and cytology is negative. This is what the lesion looks like, small papillary tumors, 2 close to each other. And the question here is, what is the best option for this patient? So we have the debate now between Dr. Buckley, who will present his option, which is resection of the tumor and intravesical therapy, and Dr. Paulo Gontero will talk about active surveillance.
Well, thank you, Ashish, and it's great to be asked to talk about the management of intermediate risk NMIBC in the case for intravesical therapy, my disclosures, and exactly what is intermediate risk NMIBC. When one looks at it from a histological perspective, most utilized the 1973 classification of histology with group 1, 2, 3, where grade 2 was the intermediate risk classification, grade 1 being low grade and grade 3 being high grade. With the more commonly used 2004 classification, the histology is basically between low grade and high grade. So how does intermediate risk fit into that histologic? Well, we know what low risk is, solitary primary low grade, and high risk is T1, G3, or CIS. Intermediate risk does have a heterogeneity that you can see in this slide. The EAU classifies intermediate risk as everything that is in between low risk and high risk. You can see on the slide here that low risk again is primary solitary smaller tumors with no CIS. High risk have T1, G3, carcinoma in situ, and size. Everything in between these two is intermediate risk. The AUA has a very similar classification for intermediate risk. They utilize recurrence rates, size, and multifocality. This is the EORTC weighting scale to predict probability of recurrence and progression at 1 and 5 years. This slide from the EAU guidelines describes the treatment recommendations for intermediate risk patients. And in patients that have a low recurrence rate and expected EORTC recurrence score less than 5, 1 immediate installation of post-op chemotherapy is recommended. In addition, 1 full year of BCG intravesical chemotherapy, intravesical immunotherapy or chemotherapy for up to 1 year for intermediate risk patients. The AUA likewise recommends the use of a single postoperative installation of intravesical chemotherapy in their guideline statement 15. Their other guideline statements recommend a 6-week course of induction, chemo or immunotherapy, and ongoing maintenance therapy in those patients that respond to the induction course. Since I'm from Canada, I thought I would throw in the Canadian guidelines that display in the middle of the slide the intermediate risk protocol, which is very similar to the European and American guidelines, recommending a single postoperative dose of chemotherapy and BCG induction and maintenance therapy for up to 1 year. So the bottom line for my argument is that all these three international and national guidelines support the use of single-dose postoperative chemotherapy and intravesical therapy, whether that be BCG or chemotherapy, for intermediate risk NMI-BC. Thank you.
I strongly believe that a small low-grade TA recurrent non-muscle invasive bladder cancer can be safely managed by active surveillance. Why? Well, several studies have shown that the long-term prognosis of this disease is extremely favorable. In spite of a high risk of recurrence, the risk of progression to muscle-invasive disease remains low, not exceeding 1 to 3% in the long term, as you can see from the tables. And this thanks to the favorable genetic background of this disease. Usually, the fate of these patients is to undergo multiple TURBTs in their lifetime, and this procedure is relatively invasive, particularly for elderly patients, since it requires at least a spinal anesthesia, and it is not devoid of complications that can be significant in up to 5% of cases. Besides, active treatment with TURBT for these patients raises significant issues in terms of quality of life without any impact on the natural history of the disease that will inevitably keeps on recurring. One may claim that minimally invasive options such as office fulguration or laser ablation could partly overcome some limitations of TURBT. Nevertheless, these procedures still are invasive in some ways and may not be devoid of complications, particularly in patients that are taking anticoagulants. How can active surveillance be defined in the setting of a non-muscle invasive bladder cancer? Active surveillance is the avoidance or temporary delay of a TURBT or any other active treatment in a patient that is placed in close follow-up and that could eventually receive TURBT at any time is needed. What is the rationale of active surveillance in a low-grade TA recurrent non-muscle invasive bladder cancer? Active surveillance aims to reduce the burden of a follow-up that is invasive, costly, and with little impact on the natural history of the disease, that is mostly harmless for the patient. Which evidence do we have to support active surveillance in non-muscle invasive bladder cancer so far? Well, from the few available studies, as you can see in the table, it appears that when a small recurrent low-grade disease, either TA but also T1, is placed under active surveillance, a TURBT can be postponed by an average of 1 year with a negligible risk of progression to muscle-invasive disease. The few cases that progress are actually more likely to develop a high-risk non-muscle invasive bladder cancer, a disease that in most instances can still be captured during a non-invasive follow-up, either by urine cytology or visual appearance during cystoscopy, and can be effectively treated. We need to acknowledge, obviously, that active surveillance in non-muscle invasive bladder cancer is still a work in progress with some unanswered questions. Information such as the average growth of a tumor under active surveillance, or which disease should not receive active surveillance, or the most appropriate follow-up scheme are still missing, and further studies are required. So in conclusions, in spite of these limitations, active surveillance in a recurrent TA low-grade non-muscle invasive bladder cancer appears safe, with hardly no progression events to muscle invasive disease, effective with more than 60% of patients still on active surveillance after the 1 year, and with a good patient compliance. Thank you very much for your attention.
So, Professor Stenzel, you heard the discussion between Roger and Paolo, and you heard the case for active surveillance versus resection of these tumors. What is your practice in this kind of situation?
Well, usually you have to go and inform the patient about the guidelines. And the guidelines clearly say everything you see, every tumor you see should be removed. So clearly you have to recommend that. You can only think about an individual situation where you may change from that.
And Dr. Rabal?
We will do the same. We are doing a TURB in this case, and only those patients with very high comorbidity that you think that you don't need an active therapy, then we go for active surveillance. But the common attitude is the TURBT.
If we elect to follow this patient with active surveillance, Dr. Rabal, and again, active surveillance is relatively common in some ways in North America. I understand it might not be as much in Europe. But if you follow these patients at your center, do you change anything when it comes to the follow-up strategy?
Well, in case that we will do that, probably we will follow as is it recommended on the guidelines, that is a 3-month strategy and then 6 months and then yearly. But since we are not used to do that, and the only case we will do that will be in those cases with high comorbidity, probably we will reschedule the follow-up taking into account this. But if not, we will do a regular follow-up.
Great. And Professor Stenzel, do you change your follow-up strategy?
Well, absolutely. I mean, how do you define active surveillance? Is active surveillance doing nothing and just comfort the patient every time he comes in or phones in? Or do you have something like ultrasound or even micro-ultrasound plus cytology? We do very excellent cytology. So if the cytology doesn't show any high-grade tumor, which we will pick up in 90%, and the sonography doesn't show anything, then this is not active. This is an active surveillance scheme that really allows you to see whether any size changes are there, or whether the cytology picks up more or a higher grade tumor.
Yeah, no, excellent points. And as Dr. Quintero pointed out in his talk, if we are going to follow these patients with active surveillance, then absolutely we need to make sure that there's no positive cytology, no indication of high-grade disease. So thank you for that great discussion, although it was short. So what about this patient? What did this patient elect to do, and what was the outcome? This patient actually elected to undergo a little bit of a hybrid, elected to undergo office fulguration with topical analgesia, which was done. These were small lesions, so they were cauterized. Intravesical gemcitabine was given in the office as well. And currently the patient is free of disease for 24 months. So again, interesting paradigm that we have to consider nowadays in the management of these low-grade small lesions. But as was pointed out, the guidelines clearly state that all tumors need to be removed and or cauterized, and active surveillance can be restricted to select situations only. Now, moving on to debate number 2. Again, this is a case-based debate of a patient with high-risk bladder cancer. In this case, it's T1 high grade. And the question is repeat resection mandatory before deciding treatment options? So this is a healthy lady, which is, again, unusual for bladder cancer, but in this case, she is 62 years old with no comorbidities and gross hematuria only. Imaging, including CT urogram, is negative. On cystoscopy, you can see a 1 centimeter tumor, as shown in the picture. It is high on the posterior wall. A resection is performed. It shows high-grade T1 disease. Muscle is present and not involved. Now, in this debate, Dr. Gontero will take the stance that repeat resection is overused and is not necessary. And Dr. Rabal will tell us why the guidelines state and why people consider read-TUR to be mandatory.
In spite read-TUR is advocated by current guidelines anytime a T1 high-grade disease is found at primary TUR, I think the evidence in support of this statement is not so strong. It is true that after a primary TUR of a T1 high-grade, persistent disease is being reported in up to 60% of cases at read-TUR. And it is also being shown by some studies that the routine adoption of read-TUR translates in a reduction of the risk of recurrence in patients who receive read-TUR. But the question is, are these two observations sufficient to support the widespread use of an additional TUR? I personally think that a stronger case in favor of read-TUR would exist if a significant number of muscle-invasive bladder cancer are missed at primary TUR, or if read-TUR has a demonstrated impact on disease progression or cancer-specific survival. And finally, if the pathology at read-TUR could be used as a valid predictor of progression and thus influence decision-making. But do we have sufficient evidence to support these statements? Concerning point 1, the risk of missing a muscle-invasive bladder cancer, the present table from a recent systematic review shows that indeed the risk of upstaging 2T2 disease at read-TUR can be as high as 10%. However, in some series outlined in red in the present table, this risk is negligible, far below 5%, supporting the notion that even the first TUR can be enough accurate in staging the disease. Concerning point 2, does the read-TUR affect the risk of progression? Well, in a sub-analysis on the largest series ever reported of T1 grade 3, it was shown that if the primary TUR is accurate enough to include muscle in the specimen, a read-TUR does not reduce the risk of progression. And the same finding holds true for cancer-specific survival. As you can see from the Kaplan-Meier curves, there is no survival advantage provided by an additional procedure if the first TUR was accurate enough to include muscle in the specimen. One may object that the pathology at read-TUR is a strong prognostic factor to prompt a change of management, cystectomy in place of BCG, for instance. Persistent T1 disease at read-TUR has long been considered as the strongest predictor of progression, based on an old study from Harry Eyre pointing out a 70% risk of progression to muscle-invasive disease. However, again in this large recent study on T1 grade 3, it was shown that the different pathology at read-TUR does not translate in a significant difference in progression, and even a persistent T1 grade 3 disease at read-TUR can be safely treated with BCG, with excellent cancer-specific survival and no need for immediate cystectomy. So in conclusion, I believe that in some selective cases of T1 high grade, immediate read-TUR can be omitted if the primary TUR was accurate enough to include muscle in the specimen. The patient can be safely treated with BCG, thus postponing read-TUR at 3 months. Thank you very much for your attention.
Thank you, Ashish. I will start my talk citing you. As you said, we need to level the playing field for surgery in bladder cancer, and not only considering robotic cystectomy, but focusing on the entire spectrum of the disease, and increasing awareness about TURV. We owe that to our patients. Although some want TURV to disappear, I think that this shouldn't be our objective. But the truth is that we need to improve its quality, even by improving using new imaging techniques or by new tools or techniques, surgical techniques, like for example, in-block resection. What says EAU guidelines about re-TUR? It's strongly recommended after incomplete initial TURV, in case of doubt about completeness, if there is no muscle in the specimen after initial resection, and in all T1 tumors. And for not being said that I am biased, look here all the guidelines, and all of them are coincident that re-TURV is mandatory in all T1 tumors and in those with no muscle or incomplete initial TURV. A systematic review analyzing more than 8,000 patients with Ta-T1 tumors demonstrated 51% risk of disease persistence and 8% risk of understaging in T1 tumors. The analysis also showed a high risk of residual disease in Ta tumors, and most of the residual lesions were detected at the original tumor location. Another meta-analysis of more than 3,000 patients with T1 tumors showed that the prevalence rate of residual tumors and upstaging to invasive disease after TURV remained high in a subgroup with the trezor muscle in the resection specimen. In the subgroup of more than 1,000 patients with T1 tumors and the trezor muscle present, persistent disease was as high as 58%, and understaging was 11%. Not only residual disease is important, but also the prognostic impact of the second TUR. In this group, in this work, we can see 40% of re-TUR tumor patients suffer recurrence compared to 71%, and progression could be observed in 6% and compared to the 24% in those not submitted to a second TURV. In a retrospective evaluation of a large multi-institutional cohort of more than 2,000 patients with BCG-treated T1 high-grade tumors, and where the second resection was performed in only 900% patients, the second resection improved recurrence-free survival, progression-free survival, and overall survival. It's true that only in those patients without muscle in the initial resection. And although the progression rate in those with residual disease seems less than those rates described by her, it is still as high as 25%. So, said that, second or re-TURV, not second TURV, re-TURV still is mandatory because we still have 25% progression rate depending on the residual disease, and this could be really helpful for decision making. It's true that we need to increase the quality of our first resection. We should be aware of our own data and outcomes. We should perform information campaigns and to raise the awareness about TURV. But in the meanwhile, being conservative, we will go in favor of our patients. Thank you very much.
So thank you very much again. Let me turn to you, Dr. Buckley, and ask you, what is your practice in these situations in patients that have T1 high-grade disease and muscle is present on the initial resection?
Yes, thanks, Ashish. I don't think 100% of the time you need to resect. I do individualize these patients. This particular patient had a small tumor. Muscle was included. So I probably would just go on to whatever therapy I was going to next, such as BCG, rather than re-resecting.
And Professor Stenzel, what's your stance in this situation?
Well, you know, we have several possibilities of really improve the histology, the specimen the pathologist gets. One is en bloc resection. If I do a nice en bloc resection with muscle in the specimen, which is negative, shows negative margins on all sides, also on the ribs. If I did a photodynamic diagnosis showing no carcinoma in situ, then I will abstain from re-resection. However, if there is carcinoma in situ, if PDD shows several areas of possible carcinoma in situ, or if there is a questionable, let's say, deeper T1, then, and of course, if the patient has a certain age where subsequent therapies are a possibility or radical therapies are a possibility, then I'll go to re-resection. It's an individualized scheme.
Yeah, that's a good point. And, you know, as Professor Gontero and Rubal mentioned, you know, you can take two sides of this argument and make a case for each one. But I do say in the United States, the guidelines and the EAU guidelines also state that repeat resection is necessary. In general, when non-bladder cancer experts are taking care of patients, which is, you know, the general urologist in the U.S., we try to make it a point that repeat resection should be mandatory simply to take away the risk of understaging and missing CIS, as you mentioned. But again, you know, when the patients are being counseled by true oncologists, experts in the field, the discussion points that you mentioned are absolutely correct. So thank you again for this discussion. So this particular patient did undergo a repeat TUR, and there was no residual disease present on the repeat resection. And we move on into debate number 3 with the same patient. So there was a discussion of the options, and the patient selected BCG therapy. She did mention, by the way, that because of her religious beliefs, she could not undergo organ removal surgery. So cystectomy was off the table, even though it was brought up as a potential option for T1 high-grade disease. So this patient underwent induction BCG, full dose for 6 weeks, tolerated it really well. At the 3-month evaluation, there was no evidence of disease on cystoscopy and cytology, and the patient received maintenance BCG. At 6 months, the cytology was positive. The cystoscopy in the office was negative, but the patient was taken for optical enhanced cystoscopy because of the positive cytology, and blue light showed patchy areas suggestive of tumor, and biopsy was performed and showed carcinoma in situ. The pathology was reviewed by second pathologist and confirmed, so there's no doubt that this is actual true CIS in a patient after 6 weeks of BCG after T1 high-grade disease. So now, what is BCG unresponsive disease? This is a terminology that is relatively new. It was developed by the International Bladder Cancer Group and the ASCO group in conjunction with the FDA and published by the FDA in their document in 2018. This is any persistent or recurrent CIS within 12 months of completion of adequate BCG therapy, recurrent high-grade Ta/T1 disease within 6 months of completion of adequate BCG therapy, or, because we all recognize T1 high-grade disease is very dangerous, in T1 high-grade disease, if this is persistent and new at first evaluation 3 months following induction BCG, then this is BCG unresponsive disease. And as I said, this has been adopted by the FDA, and investigators and industry are allowed to use this definition and perform single-arm studies for registration purposes for various drugs. So, considering that this patient has BCG unresponsive disease, the question now is, since we know that, for example, Keytruda is approved, pembrolizumab, in the United States for the situation, is it time to use systemic IO therapy for BCG unresponsive disease when a patient refuses radical cystectomy for recurrent disease, in this case, patient with T1 high-grade disease that started out and now has CIS?
Hi, Ashish. Thank you very much. We will start saying how difficult it is to define the unresponsive or refractory disease to BCG therapy. And obviously, we need clear guidance, not only for clinical trials, also for real life. The second point we should mention is that by now the standard therapy for VEJIGA failure is radical cystectomy, but said that it's true that IO therapy could probably open the door for some patients by now not suitable to be submitted to the standard therapy and that they have not any other alternative. We should consider and we should to know that those patients not responding to VEJIGA therapy are at higher risk of progression, and it's for that I think that we should incorporate as primary endpoint the progression-free survival. Considering all the introduction, we should know which is the cancer-specific survival for the standard therapy by now, that is the radical cystectomy, and that we will incorporate as a control arm in phase 3 trials. That there are a lot of IO therapy that are being tested in bladder cancer. We already know from years that it has demonstrated impact in muscle-invasive disease, but it has been demonstrated its impact in non-muscle invasive disease unresponsive to VEJIGA. It was presented by first time in 2019, the outcomes of pembrolizumab during ESMO. And this was enough to achieve and to obtain the FDA approval. This year, in 2020, we can see the update on the outcomes of on pembrolizumab, use it in a high-risk non-muscle invasive disease non-responding to VEJIGA therapy. Among 102 patients initially enrolled in the trial, 96 were included in the efficacy analysis, and the median follow-up was nearly 30 months, and the complete response rate was 40%, and the median duration of the response was 16 months. So this is an impressive outcome. Notably, there were no instances of progression to muscle-invasive disease or metastatic bladder cancer while they were on the study, and median progression-free survival and overall survival were not reached. Progression-free survival, as I mentioned, that is a good endpoint and should be the primary endpoint, was 82% at 12 months, and the overall survival, 97%. So these are impressive outcomes. Following discontinuation of study treatment, 37% underwent radical cystectomy. And among these 36 patients who underwent radical cystectomy, 3 of them showed a PT2 disease, while 91% still not have pathologic upstaging. In this updated analysis, treatment-related adverse events were similar to those of the initial analysis. There are other trials coming that will test the future of IO therapy in bladder cancer, as Keynote 676 or Potomac study, or even ADAPT bladders. So for the first time in a setting where we do not have alternative for those that could not be submitted to standard therapy, that is radical cystectomy, we have the evidence that a second-line therapy based in IO therapy can achieve complete response and probably have an impact on progression, although we need a larger follow-up. We should analyze properly the side effects. We should understand how to select our patients, which therapies and which markers could help us to select, and finally, the cost-effectiveness of the therapy. But yes, IO therapy is here to stay for some of our patients.
Now, after your crushing arguments, Maria, I think we should look at some other options for this poor lady. And this lady, we have to ask ourselves, did we really correctly stage her? We have the tools. MRI, VIRATs give us the possibility to reduce the amount of understaging in these patients. Correct staging also comes sometimes with a VTR. Several studies have shown that by doing a VTR, assessing the correct stage, the time to progression may be prolonged and increased. And also the quality of the TUR. If you do an en-bloc TURB, an en-bloc resection, the pathologist gets a better specimen. He can better evaluate the depth of the disease and the margins. A high-risk non-muscle invasive bladder cancer is not the same in every patient. We know now from data like here from Paulo Cordeiro that older patients with larger tumors, and those with carcinoma in situ have lower progression-free survival rates at 10 years. This is the slide Maria Ribal has already shown you, and it's an example of why we debate the use of checkpoint inhibitors in non-muscle invasive bladder cancer. Checkpoint inhibitors can be dangerous drugs. They can cause side effects which may be dangerous to the patient or may even lead to lifelong side effects requiring substitution therapy. 57% of the patients had a complete response at 12 months. However, the median duration of that complete response was 16 months, which is, in our view, looking at the fate of non-muscle invasive disease, not really enough. It should be actually 2 years, and we are waiting for these. We have to wait for these data, because some of these patients not even reached a 12-month follow-up. And half of the patients, which were complete responders, had a subsequent recurrence of non-muscle invasive bladder cancer, which means they may have had carcinoma in situ again. And there was even one death in that population of approximately 103 patients, which means there's a 1% mortality with this treatment. If you compare the older series with VTR in non-muscle invasive disease and compare it to this study, then you see the results are not looking that exciting, especially because they don't have the long-term results with regards to time to progression yet. There are other possibilities. We have more tools than just IV checkpoint inhibitors for the moment. It's not only the checkpoint inhibitors given topically, intravesically. It is also the possibility of combining, for example, chemotherapy with hypothermia, or to get more molecular markers like FGFR3 alterations, and then look at the possibility of using FGFR3 inhibitors, or alternative ways of BCG and variants of BCG. So we need to explore other possibilities, less dangerous ones, before we go in this type of treatment. Thank you very much.
So, Professor Gontero, you heard both sides of the argument, and let me ask you, what is your current evaluation of the data as it exists? Would you use pembrolizumab or other IO agents in this particular patient, or would you go with intravesical therapy as outlined by Dr. Stenzel?
I would still go for intravesical treatment in this case, because I think the data that we have so far on pembrolizumab are, in spite of being promising, I think still not mature yet. So I think we need further evidence.
Does the side effect profile of pembrolizumab give you any cause for concern, Dr. Gontero?
Well, certainly if we compare the side effects of either repeat BCG in this case, or going for second-line intravesical chemotherapy like gemcitabine, where we have been shown an excellent safety profile, if we compare this with the potential side effects of pembrolizumab, I probably think that we should wait for further studies before we can accept this type of absolutely intriguing immunotherapy as an acceptable option in this case.
You know, I think it's interesting because if you look at the efficacy of pembrolizumab in Keynote 57, it actually was a lot better than many people expected with systemic agent to get, a 40.2% CR in the bladder with CIS, and then durable to about 16 months was fairly impressive. But a lot of urologists and patients have had concerns about the toxicity profile. Dr. Buckley, let me ask you, in Canada, for example, in urology group practices, Would the urologist be administering the pembrolizumab, or would it be something that is referred to the medical oncologist?
This would go to the medical oncologist currently in Canada, and it's really just available under clinical trials at the moment. So it is somewhat limited, but increasingly available. So it would depend whether we would stick with chemotherapy, some sort of option that we've been doing for a while, or refer it on to another center that may have that clinical trial.
Yeah, I think, again, for the bladder cancer community, for our patients, us, having a drug that is now approved by the FDA after many, many years is a big win. And clearly it's an option for our patients who refuse radical cystectomy. But as you heard in the discussions, it's something that we have to consider based on a good, informed discussion with the patient. But again, I think it's a huge win for our patients to have an option that is now FDA approved. So again, thank you very much for that discussion. Let's see what this particular patient opted to do. This patient had a discussion with both my office and with the medical oncology office and did not like the side effects of IO therapy. She decided to enroll in another clinical trial that we have available at our center, and that is using combination intravesical chemotherapy. And the patient is currently on protocol. Again, it's not been long enough to see what the outcome is, but this patient was an example of someone who heard the side effects of pembrolizumab, and even though the data seems encouraging, decided against it. So with that, we now move into the last talk, which is the state-of-the-art, what's new in the medical management of upper tract urothelial carcinoma in 2020.
Hello everybody, I'm back again, this time talking about the medical management of upper tract urothelial cancer. In the guidelines, we see that there are possibilities in the surgical treatment or in the medical management. We'll focus here on the medical management and mainly on the medical management of the so-called superficial disease. Well, I've shortly touched systemic therapy and the experimental approaches. The upper tract urothelial cancer is divided into the low-risk disease, where all criteria listed here must be met, and the high-risk disease, where only one of these criteria listed here is sufficient to classify it for a high-risk tumor. For the patient selection of the medical management, actually in the guidelines, only low-risk upper tract urothelial cancer patients are recommended for such a treatment. There is a high recurrence rate in patients with carcinoma in situ of the upper urinary tract. However, in correct selected patients with renal-sparing therapy, no real significant difference in cancer-specific survival and overall survival is seen when treated with appropriate forms of medical treatment. The challenges are that the upper tract urothelial cancer is a rare disease. We only have retrospective data, we only have small cohorts. There are various therapeutic possibilities and different application approaches. So that makes these data heterogeneous, and we cannot make a really clear conclusion either with the approach nor actually with what type of therapy we should use. Most data for which we have right now are for mitomycin C or thiopenta, depending on which side of the Atlantic the study was done, and BCG as the immune installation therapy of choice. For mitomycin and BCG installation, we see a reduction of the recurrence rate, but no clear data with regards to overall survival. It's a difficult way to access the upper urinary tract. We can do it with the antegrade installation via percutaneous nephrostomy. Potential seeding of tumor cells is a problem. We can do it with a retrograde installation with the ureteric stent. it needs repeated X-ray and may cause a possible ureteric obstruction at the time of the installation or after removal of the catheter. And there is a possibility of doing a retrograde application using a refluxing via a double J stent, but it's been shown that this leads to an insufficient drug dose in renal pelvis. What we also have to be careful is the height of the installation bottle or the installation device, because it should not exceed 20 centimeters H2O, because the pelvic calyceal system is not really made for withstanding a higher pressure. Now, with BCG immunoinstillation, we can see that we can get really good data with regards to progression-free survival, cancer-specific survival, and overall survival. It's retrospective data, though, but it shows that it seems to be equivalent to a renal ureteric ablation or excision of the upper tract. Now, with regards to carcinoma in situ versus T1, T8 tumors, it shows that the successful carcinoma in situ alone is better, and it is less promising in the TA, T1 tumors with upper tract immunotherapy. The series are small. They're all together in this overview. There are about 140 renal units that are published, and the data, the median follow-up in some of these series does exceed the necessary 2-year, 24-month, and it shows that it is an effective treatment in upper tract urothelial cancer compared with radical surgery. Now, with regards to chemotherapy, the problem with chemotherapy is it's not really the best treatment for carcinoma in situ. For TA, T1, and carcinoma in situ, if you would use chemotherapy, you would want to have the chemotherapy lasting as long as possible at the site of the disease. So this thermosensitive gel actually seems to be a possible solution. Data have been shown the last time, just recently, at the virtual AUA, where the upper urinary tract, the gel was infused in a cold, coming out of the fridge, with a ureteral catheter, and with the body temperature it transformed into a gel and allowed a prolonged and location relevant diffusion of mitomycin, or release of mitomycin out of that gel. And 58% at the interim analysis of patients with carcinoma in situ had their tumors disappear following their initial course of the treatment. We'll wait for more data to see whether this is going to be our treatment of choice. Systemic treatment, I said, please look at these tables, and we'll go on beyond. The same with the experimental approach. Just mentioning, we're trying with physical possibilities such as radiotherapy or ESWT. Everything work in progress. We have not seen any really breakthrough yet, but it could be promising, especially with some new forms of immunotherapy. So in conclusion, these are the EAU guidelines, and I highlighted the conclusions which we have nowadays in 2020. Percutaneous nephrostomy and retrograde installation with a single J open-ended ureteric stent are the applications of choice. A double-J stent is seen as suboptimal. Chemotherapeutic agents and immunotherapy with BCG are the possibilities which we have right now. If the gel is going to help the chemotherapeutic agent, we'll see. And we have to be aware that the efficacy is only based right now on retrospective small studies. Thank you very much.
Thank you, Arne, for that very enlightening talk and state-of-the-art on upper tract urothelial carcinoma. Let me open it up for a brief discussion with the panel members. Maria, how do you manage patients today that have multiple low-grade tumors in the upper tract? Do you use the gel-mido type ablation therapy, or do you do percutaneous or other installation of conventional chemotherapy or BCG?
Actually, in our practice, in our department, we are not using the mitomycin gel because we still believe that the evidence needs further assessment. And what we are doing in low-grade disease is just to use retinoscopy just for preserving the kidney and the urethra. So we are doing this, and we would rather prefer to manage surgically, but in a conservative way.
Okay. Dr. Quintero?
Well, I think the management of multiple recurrent low-grade upper tract tumors is quite crucial, and I honestly, in our institution, we are really quite reluctant to use any sort of drug that we use for intravesical tumors, and we actually are more prone to stick follow-up of the upper tract, and we tend to follow up every 3 months, and we tend to ablate those cases. Obviously, we are talking about imperative indications in these patients, because otherwise, even if it's low grade, if it's multiple recurrent and the patient has a normal function and 2 kidneys, we consider nephroureterectomy.
Professor Stenzel, let me ask you, I mean, again, your talk highlighted all the key points, but would you ever recommend a nephroureterectomy for a patient that has documented low-grade tumors in the upper tract? And if so, when would you recommend it?
Well, I would say I would say the majority is low grade. We try to make kidney sparing surgery, be it that we either take that segment out if it's in the ureter, because that's really important. Where is the location? The other thing is, of course, if it's a very, very large tumor, which has also some problems like bleeding, and then you might consider a radical nephroureterectomy. But you know, I've really gone beyond that in a bilateral tumor in the renal pelvic calyceal system, extensive, that I even did an open resection and afterwards radiation in a patient who really absolutely refused any dialysis. So you have to individualize these situations. But most of the time, nowadays, with all the possibilities which we have, kidney sparing surgery, especially in the younger patient, I think is almost a must.
Absolutely. Now, let me circle back to the first talk that Dr. Buckley had given on strategies to optimize the use of BCG during times of shortage. Professor Stenzel, what are you doing in Germany during these times of BCG shortage? How do you triage patients? Who do you offer BCG to versus chemotherapy? A
very simple answer. We don't have a shortage. but that's not what you want to hear, of course. But, in case of a shortage, which we had before, we would more or less try to just reduce it to the high-risk patients. And then also, there's data that you must not always go beyond 12 months, especially because of the side effects and of the real effect of a 24 or 36 months maintenance therapy. We try to avoid that, and we also try to avoid it in intermediate risk patients.
Yeah, no, we're facing a shortage in the United States, of course, with a single manufacturer of BCG. And as you know, there are multiple studies across the globe, including ours in the U.S., that is using BCG as a vaccine for COVID-19. Our hope is that, the renewed interest in BCG, including the millions of dollars that Bill Gates Foundation has provided, will allow more production and availability of BCG everywhere in the world, not just in privileged places like Germany, Arnold. So in closing, because we're running short of time, I would like to give each one of you 30 seconds to give us your top thoughts on non-muscle invasive bladder cancer. And let me start with the lady. Professor Rabal, your 30-second highlight on thoughts on the status of non-muscle invasive bladder cancer in 2020.
Well, I would say that we need to focus our attention in the TURB. We need to improve our outcomes in TURB. We need to take care and we need to be aware of how to do it. I would say that although it's true that we will have alternative therapies for treating this disease, still in a high risk, non-respondent, non-muscle invasive disease, radical cystectomy and early radical cystectomy should be an option. So, because it has a lot of proportion of progression. So these would be my two messages: to take care of the TURB and how we do it, to follow up our patients, and to be sure that there are some high-risk non-muscle invasive disease that deserve early cystectomy.
Great points. Professor Grantera?
Well, I think that we need to individualize the treatment as much as possible and go beyond the dogma of non-muscle invasive bladder cancer. Reach UR can be viewed as a dogma, and I think that if we, with the improvement in the resection technique, being very careful, I think that many procedures could be avoided. We need obviously to produce more evidence in this respect. But also we need to go beyond the dogma when we talk about the treatment, and I think that from this point of view, active surveillance in highly selected cases is a way that can be pursued, particularly for patients who are elderly, comorbid, and also where we really don't want to jeopardize too much their quality of life, because undergoing multiple resection, sometimes when you don't have any evidence that you change the natural history of the patient, I think it can be pointless. On the other hand, obviously, all our efforts need to be concentrated in the high-risk disease, as Maria was already mentioning, and in this respect, I think our treatment option needs to find a way of an effective treatment, and we certainly need to try to pursue this new avenue of new second-line treatment that aim obviously to potentially reduce the need of radical cystectomy in high-risk disease.
Great points. Professor Stenzel?
Well, you see that cancer of the bladder and the upper urinary tract can be a deadly disease or a non-deadly disease, which is not really worth of sacrificing an organ. Our initial goal, of course, is not to put the patient into a risk for death. The other one, however, is to spare organs that we should not really sacrifice. We can do that now with a lot of technical possibilities, photodynamic diagnosis, en-bloc dissection, virets, and all the other stuff. I think we should use all that and really make quality of life and long survival of the patient possible. End of statement.
Thank you so much. And Roger, your highlights?
Well, thanks, Ashish. Well, we have our surgical techniques, I think, are better than what they were in the past. We do have our standard immunotherapy and chemotherapy, but I'm really excited for the future because we have a whole plethora of new things that are coming down the line, and I think it's going to be better for patient outcomes. So I'm excited for the future.
Great. So, we are short of time, so I would like to close now by, first off, thanking you, the audience, for your attention during this seminar, and especially my panelists who have taken the trouble to put their talks together, come together and provide this very educational webinar for us. And of course, the sponsors and the EAU for allowing us to do this in a virtual format, even though we always like to be there in person. We hope to see you next year. Thank you very much, and everybody stay safe.